I think you saw my disclosures for this talk. I am a big guidelines type person, and so I've been involved in the lung cancer guidelines. I know a lot of people in this room are probably NCCN folks, but the ACCP does a phenomenal job, and there are 27 chapters about anything you could think of in lung cancer related, and they're all evidence-based, we think, to the best that we know about. My chapter from 2003, this is the third update of the lung cancer guidelines, or methods of staging non-small cell lung cancer, and that was just published in the spring of this past year. I worked with some great folks. Frank Detterbeck's probably one of the most thoughtful lung cancer surgeons in the country, and this is a pretty good group of folks. So why stage? Accurate staging is critical. The treatment options are stage dependent. Prognosis is stage dependent. Enrollment in clinical trials is stage dependent. It really provides a common language. I can call Corey up on the phone. I almost slipped and said on the road because that's where you'd probably find him, and say, hey, Corey, I got a 4-centimeter right upper lobe mass, ipsilateral right hilar and mediastinal adenopathy, no evidence of metastatic disease. He knows exactly what, he knows this is stage 3A, and we can talk about the differences and nuances of treatment. And it allows for study of large cohorts. I'm a health services researcher by training, and I love this idea of studying lung cancer in large cohorts, like the STEER data set, rather than single institution or even the cooperative trials, which highly select patients. If you look at the large cohorts of patients, you can get a lot better understanding of what's actually happening in your community. And how important is it now? I mean, we're getting pretty detailed in our treatment, and if you look by stage, you can see that, stage 1's basically treated with surgery or SBRT if they're inoperable. Stage 2, surgery, adjuvant chemotherapy. Stage 3, chemoradiotherapy, and stage 4, chemotherapy, targeted therapy, and supportive care. So you get this wrong, you're probably going to give the patient the wrong treatment. And I see 5 new lung cancers a week. I have a full day in a cancer center, and I can tell you probably the biggest mistake I get for second opinions is misclassification of stage and the wrong treatment being started before the patient was appropriately staged. And so for staging, we have some non-invasive and invasive approaches. The non-invasive approaches include CT and PET, and the invasive approaches include minimally invasive, like the needle techniques, and then surgically invasive, like mediastinoscopy, mediastinotomy, the Chamberlain procedure, and VATS, as you can see. And so why bother with invasive staging? There was this patient had a PET, and we gave the option in that case of just going directly to treatment, which I think is a massive mistake, in my opinion. Isn't CT and PET good enough? This was just updated through a meta-analytic approach, and we published this in the guideline. If you look now, and I can tell you this has changed over the time that I've been working on the guideline. In over 7,000 patients with CT, the sensitivity for an enlarged lymph node in a patient with known lung cancer. So you have a lung cancer and an enlarged mediastinal lymph node. So the sensitivity is about a coin flip. All right, it's just better than a coin flip if you have an enlarged lymph node about whether it's cancer or not. A bit more specific, but not really sensitive. And the problem here is that we get enlarged lymph nodes throughout life from things like sarcoid or granulomatous disease or histo or other reasons, and so you just can't trust that enlarged lymph node. PET's better, but it's not perfect. And if you have a false positive PET in up to 15% of your patients and act on it, they may have been surgical candidates, and now you've said, oh, you're not, you're going to get chemoradiotherapy. Why do we see false positive PETs? Post-obstructive pneumonia from the tumor and other reasons. So the one cool thing about PET is that I really start trusting data when I get into the thousands. And so in the first series of guidelines in 2003, we only had about 1,000 PET scans, and now you can see over time we now have over 4,000 PETs in this database. And again, these are highly well-selected patients with known lung cancer where we have the gold standard for surgery to know whether those PETs were positive or not. And so our recommendations in the guideline in patients with discrete mediastinal node enlargement and no distant Mets, with or without PET uptake, invasive staging is recommended. And in patients with PET activity and normal appearing nodes by CT and no distant Mets, we also recommend invasive staging. I'm going to go on to talk about those. And a level 1C is a good, solid recommendation. 2C is not such a great recommendation. 1C is good. I actually pushed for, since there are randomized trials, for a higher level of evidence, but was outvoted by people who can outvote me, I guess. And so they did. So how do you confirm diagnosis? You know, there are a myriad of ways, and the one thing I'd like to get across to you, even though I'm sort of an EBUS guy, is I don't care. Just make sure you make the diagnosis. I don't care. Use them. If you have really talented thoracic surgeons who do a great mediastinoscopy, by all means, use them at your institution. But a lot of it actually is based on how, and this is sort of the nuance, based on what it looks like when it appears to you in your clinic. If you have the upper left-hand corner with extensive mediastinal infiltration in a patient who's performance status 3, and you just kind of, the family wants to know, really, is this cancer? You can actually use sputum cytology in this patient. You'll probably get a diagnosis, right, if they have some hemoptysis, or a blind or an image-guided needle, the old Wang needle biopsy. And so you might want to go ahead and do that in that patient. In the second patient down on the left, discrete mediastinal lymph node, we would use EBUS in this patient, but mediastinoscopy would be fine. In the patient in the upper right who has no mediastinal lymph nodes but a post-obstructive pneumonia, they actually have a high rate of micrometastatic disease, and we would say they should be staged in the mediastinum. And then the one that's the most controversial and the one that I'm sort of interested in from a lot of different ways is what to do with these peripheral nodules, and I'll tell you about our recommendation in the guideline with very little evidence is that these could go directly to surgery with a thoracotomy and mediastinal lymph node dissection because the rate of mediastinal infiltration is very, very, very low in these, 5%. Is it cost effective? If you could find 5%, I don't think we know the answer to that question. So these are just these radiographic groups in better descriptors, and that's in your slide. And what we would say is the level of nodal involvement depends on their radiographic infiltration there. And what we do here is say in the guidelines that, look, even though there's no mediastinal lymphadenopathy here, the false negative rate of PET and CT is just too high. You need to go ahead and do some mediastinal staging. Same with here. Here you see that the false negative rate of a normal mediastinum here is very low indeed, and so you could probably go ahead and just take that patient directly to surgery. And again, here are the methods that we can use, and we take painstaking look in the guidelines to see which method is sort of best, and we can talk about that as time goes on. But what I will tell you is that you have some really good methods at your disposal. And here, mediastinoscopy, what was previously the gold standard, is a 78% sensitivity, 100%. They're all sort of 100% specific. EUS, EBUS, and the combination of the two has very, very high rates, very high sensitivities. And what you'll see here is we're now getting up into the close to 3,000 range in using this technology. What I would point out is EUS is falling off. Gastroenterologists are busy doing colonoscopies, and they're not really spending a lot of time doing EUS. And in a very short period of time, more patients are available in the medical literature with EBUS. So what ended the controversy about mediastinoscopy and EBUS, and I was loving that controversy. It's one of those academic fun things. Surgeons get up and pound the table and say, you must do a mediastinoscopy. But there was a randomized trial in Europe published in JAMA in 2010 that said, look, if you do EBUS, EUS first, you'll cut the fetal thoracotomy rate essentially into less than half. So you have much less, and it's a much safer procedure. The complication rate was equal in both groups, the randomized group to mediastinoscopy or EBUS. But the EBUS people who were negative went on to MEAD, and so all the complications were found in the surgical arm of that group. Now listen, I'm not here to tell you that mediastinoscopy is a dangerous procedure for the vast, vast majority of patients, 98.5%. But when it goes south, and people in this room who are senior will know this, when it goes south badly. Bad bleeding, crack in the chest kinds of things. So if what we've said after this combination of trial and the data I presented in the last slide is in 2007, we'd say, look, pick any of these invasive procedures, MEAD, EUS, EBUS, even TBNA, although the sensitivity is very poor there. In this iteration of the guidelines, we suggest EUS first over surgical staging as the best first test. So we believe the new gold standard is EBUS. So how about this extensive mediastinal infiltration patient? I'm going to take you through each of these first. There's no discrete nodes visible in casement of the structures. It's clearly 3B by virtue of it being T4. And we say whatever is easiest to get at that patient, get at that patient. Particularly if you're going to treat. If you're going to treat, you want molecular markers. I haven't talked about that yet. So you probably do want to go with one of the needle techniques to get enough tissue for molecular markers. And we could talk about what's enough tissue during the question and answer session. In this patient with either discrete mediastinal node involvement or post-obstructive pneumonia in a central lesion, we would say that we would use EBUS or one of the needle techniques first for that patient population. And then for patients with left upper lobe tumors, I put this in specifically because I think there's a misunderstanding about what technique can get to the AP window, the aortopulmonary window. And for those patients, the only procedures that can get to that is the left anterior mediastinotomy, the so-called Chamberlain procedure. We make a small incision between the second and third rib on the left and put in a mediastinoscope and get that node. But most of the kids these days, they don't do Chamberlains anymore. Most of the kids growing up are learning on VATS, which I think is a much better procedure, and they can stay with the VATS if those mediastinal nodes are negative and go right to a resection with a VATS approach. So I would say most younger surgeons around the country are using VATS for this lymph node station, but you can't get to that with the needle unless you're willing to go through the aorta. Some of my fellows try to do that on a daily basis. I don't recommend it. And those are the lymph nodes on the other side of the aorta, so you can see the trachea here, and you wouldn't really want to pass through either the pulmonary artery or the trachea to get to level 5, 6 lymph nodes. So then this issue, again, I want to just recover it for a moment on the patients with peripheral stage T1a tumors. And here with a lower grade, grade 2B recommendation, we say you can forego any type of mediastinal staging and go directly to surgery. Again, surgery includes a lymph node dissection for these folks, and so we would recommend going straight to surgery. I'm not sure if that's a correct recommendation. I want to illustrate and finally, just with two brief cases. This is a 62-year-old, 20-pack year history of smoking, had an abnormal chest x-ray prior to a herniorrhaphy, spiculated lesion you'd see here. And this patient had a normal-sized lymph node. I just want to go back and show you, but this is a normal-sized lymph node, but hot on PET. So in this patient, we would do a EBUS as a first test because it doesn't make any sense to go ahead and biopsy the lung lesion with a needle biopsy and put them through the 15% risk of pneumothorax. And we would go straight to EBUS, and this patient was diagnosed and staged with an adenocarcinoma 3A. Went from surgical candidate on that first look clinically to a non-surgical candidate. Case 2 is another patient, 76-year-old, never smoker, chest CT for abdominal pain. You can see the lesion here. There's no evidence of mediastinal lymphadenopathy on CT, although it is hot on PET. And this 10R region, which is the hilum, also hot on PET. And so this is a patient, and this is where I hate to see the mistake being made. It's in kind of the right drainage area for the same-sided lesion, and it's really easy in this patient to go stage 3A, ipsilateral mediastinal adenopathy, let's give chemo-RT. But this is a true case where the patient pre-EBUS had a T1N2M0 stage 3A lesion. Post-EBUS, it's T1N0M0, and we had found granulomatous disease, and we're in an area where sarcoidosis is endemic. And the patient had granulomatous disease, was resected, and had a stage 1A adenocarcinoma. So there are some other tidbits from our staging chapter I want to share with you. Patients should get a good clinical evaluation. You know, it's hard to impress upon my medical students and residents that we don't work backwards from a CT anymore. But for the clinical evaluation of lung cancer patients, and I think our oncologists and other healthcare providers, our physicians, assistants, nurse practitioners, we like to press on the supraclav areas to look for supraclavicular lymphadenopathy. We like to ask questions like, do you have pain in your long bones, which might be evidence for metastatic disease. We like to ask for subtle personality changes, which might mean metastatic disease to the brain, which presents in 10% of lung cancer patients. And in patients with known or suspected lung cancer who have an abnormal physical evaluation, CT or additional imaging is recommended. And then the other thing we would say is PET treatment should be gotten. I already talked about that. Patients with abnormal findings, you have to pathologically confirm them, especially for metastatic disease with a single metastatic focus on PET. There are false positive PETs, particularly in the spine, from low back pain and other issues. So you got to confirm it. Now listen, if someone's had a 40-pound weight loss, has an 8-centimeter mass, multiple rib mets all over the place, no, I don't think you have to confirm that. But if it's a single focus, you need to do that, particularly in places like the adrenal gland and single bony sites. So in summary, multiple tools exist for the diagnosis of lung cancer, and they kind of depend on our patient presentation. By the way, if you do have a single metastatic focus, for example, in the liver, along with lung disease and mediastinal node involvement, go after the site that gives you the highest stage the first time. So biopsy the liver and not the lung. It takes a procedure away from me, but it's better for patient care. Stage dictates treatment options and prognosis. Treatment varies significantly by stage, and you got to confirm stage by whatever mode's available to you. What's your best local practice? Because that provides the best quality care. And Corey, as you know, I can't thank you enough for having me back to my hometown in New York City, and I'll be thanking you for your kind attention in the audience. Thank you.